right, welcome back to the Advancing Healthcare Innovation Show. I'm Michael Stamatinos, your host. And if you're new to us, we're crazy passionate about healthcare innovation and adoption. And our aim is to bring real stories from real people that are innovating within our healthcare space. And look, we've got an action-packed rest of the year for you. And if you haven't checked out any of our previous interviews and podcasts and webcasts, make sure you do that. And just for today's date, I'm super excited to bring our next guest, Sloan Saunders, the CEO of Intellihealth. Welcome to the show, Sloan.
Thank you very much for having me, Michael.
Awesome. So, ever since we've kind of first connected and met, I've been fascinated with your background, especially since you've kind of come from the investor realm to now heading and leading up Intellihealth. Normally it's the other way around. You go from being an entrepreneur to then to the investor. But share with the audience a little bit about sort of your history, your background, and then sort of how you've kind of come to lead Intellihealth and the problems that you guys are solving.
Yeah, no, absolutely. I guess most of my professional career, I've been on the other side. So I did a business undergraduate at Georgetown, started in investment banking, then private equity, did a little venture, and then for the last decade or so, effectively ran my own family office. How I ever got into healthcare is actually via my wife. So as she completed her medical school training at Weill Cornell, did her internal medicine residency there, she became the first fellow in obesity medicine at Weill Cornell's Comprehensive Weight Control Center in New York City. And that is really where the journey for Intellihealth started for me, as I started to peer over her shoulder and learn about what obesity medicine actually was, how it functions as a chronic, disease. I was fascinated, more so initially from, a business perspective, because that's the historical lens that I've looked through the world on. But as I really started to understand just how misunderstood obesity is, and just the tools that are available, but most people aren't aware of, that really became, was her mission that I guess took up arms with in helping to solve. And that was, really, our pursuit in starting Intellihealth and taking what one of our other co-founders, Dr. Louis Aroni, who's been a pioneer in the obesity medical field for the last 30 years, has done over the course of his career and really helping to shout it from the rooftops.
So let's talk a little bit about some of those misunderstandings, some of those misnomers, because I think there's some things that maybe we can set aside and then kind of build off of that. So maybe you can talk a little bit about how obesity is viewed and maybe how you guys kind of classically define it now.
Yeah, no, absolutely. And again, a lot of this was initial learnings for me about 7-8 years ago when my wife began her clinical fellowship in obesity medicine, later joined the faculty and, became an obesity specialist. What were really first and initially intrigued me is she was the first clinical fellow in obesity medicine at Weill Cornell. So how is Weill Cornell, 7-8 years ago, starting an obesity fellowship, a disease that, everybody's heard of for the last 20, 30 years. And, the fact is that, obesity as a medical subspecialty is actually a relatively new field of medicine. So it was only in 2013, I believe, that the American Medical Association designated obesity as a disease. The accreditation body for the field, the American Board of Obesity Medicine, our co-founder, Dr. Roney, helped to co-found that organization. That was only started in 2011. So, coming up on 10 years, currently there are about 6,000 board certified obesity specialists, taking that exam. But I guess the year of training that Catherine, my wife, went through to become a fellowship trained specialist, there are about 75 obesity fellowship trained specialists in the US. So, when I start to, take a step back and really think about it, it's a classic supply demand mismatch. So even the 6,000 board certified specialists, there are not enough of them to treat the 180 million Americans who needs this type of care. And the numbers are staggering. So, I think the New England Journal came out with a study estimating that about 74% of the US population is either overweight or obese. And this is pre-COVID. they anticipated that number getting to closer to 80%, in the next, now it'd be, another 5 to 10 years. I think, everybody thinks that number has accelerated, due to COVID. So very limited number of supply of specialists, very large number of patients who need that type of care. And in effect, that's the North Star for Intellihealth. How do you democratize and scale access to effective obesity care? And to your question earlier, in terms of, why it's such a hard disease to treat and what are the ways to actually deduce effective treatment, I think it really starts with a lack of information available to both patients and even clinical providers. So I think, from a popular perspective, a lot of people don't really understand how obesity functions, how it is a multifactorial disease, body weight, regulation of hormonal and metabolic pathways. And it's not a disease about willpower or laziness. Your body, and this is what got me, really interested initially, they've actually started to measure inflammation of an area of the brain called the hypothalamus, that helps to disrupt feedback loops to, change your, ability to feel full, stimulate cravings. And as you, gain weight for a myriad of reasons. And in the US, about 15 to 20% of the obesity epidemic is attributed to drug-induced weight gain. So medications, that someone is taking, probably prescribed by another clinician, has a side effect of weight gain. And so one of the first things that, a clinician does is think critically about what current medications you're on, and then try to optimize everything else about your behavior and your environment, to really think critically about what an effective treatment protocol looks like. But I think one of the main things is that most people don't really recognize how much your body plays into, the weight gain, weight loss, continuum. And most people just, put it to sort of laziness or lifestyle.
It's interesting that you point out that these are stigmas that very much exist today, even with clinicians passing judgment on patients, thinking that there's a lack of willpower, and just the fact that you just mentioned that, look, this is something that's outside of that. This is something that is, biologic. And, when you mentioned about democratizing and providing access, this is a major problem. This was a major problem prior to COVID. And it just sounds like, COVID only amplified it moving ahead. How was this a problem that beforehand was an issue, people recognized it, and now it's just been sort of advanced higher? So I guess the question is how proactive have people been now, given the weirdness of the last 15 plus months? Is this become even more of a priority, knowing that maybe before it was something they thought about but they didn't take action on? I guess what changed that's now made this something where, man, we have to take action on this?
Yeah, it's a very good question, because I think it's a multi, factorial sort of conundrum that we're in, meaning that, COVID in certain respects has definitely accelerated the advancement of what we're doing, right? From a telehealth perspective, from a attention perspective to obesity. I mean, the data with obesity and COVID is really unfortunate. I mean, for lack of a better word. I mean, there's data coming out of New York Presbyterian that the average age of someone in the ICU with COVID is 74 years old. The average age of someone in the ICU with COVID and obesity is 54 years old. So, it's not, 100% accurate to say that COVID, obesity takes 20 years off someone's life, but there definitely is a correlated impact to the severity of COVID cases, and weight, and specifically obesity. That is a complicated analysis that is due, Dr. Roney or Catherine can speak on sort of, how that is, complicated due to obesity. But I think the epidemic, the pandemic has definitely spotlighted, what we're doing. But I think it also has, the pandemic has also burdened a lot of the partners that we have. So, our current customers, or the organizations that we currently collaborate with, like New York Presbyterian, Mass General Brigham, Hospital Corporation of America, Indian Health Services, and the Veterans Administration. All of these organizations were, pushed on their heels when the pandemic hit. And so I think, there are obviously priorities that they've, outlined over the last 12 to 18 months because of that pandemic. But I think one of the interesting things that have developed from that is just the appreciation, the requirement, and the need to start to implement these types of programs, not necessarily to try to address the risk factors associated with COVID, but recognize the broader implications of overweight and obesity has on other chronic conditions. And there's about 200 other chronic conditions that obesity impacts, but also, possibly the next pandemic or other areas. So I think, it has been a compounded development, for us as a company. But I think, and everybody, I guess, across the spectrum. But I think what was learned from this experience is just how needed a solution like this is as we move forward and come out, of the fog of COVID. What additional things really we should be doing as a society. And to your point before, obesity is a very disproportionate disease. And, unfortunately, I think, it afflicts certain populations, due to a myriad of factors, socioeconomic, being one of them. And so, again, the fundamental problem or the disconnect that we're trying to solve is that according to guidelines, less than 2% of patients are actually treated according to those guidelines for obesity.
What gets in the way of that? What gets in the way of them getting that type of treatment?
Yeah, and the comparison for diabetes is 86%. So, I want to give a comparison because, for most, chronic conditions, it's not 100%, certain, effective treatment, but obesity is categorically a massively undertreated chronic condition. And I think it goes back to the novelty of the relatively new research and available interventions that have come to market recently or that are starting to come to market. And I think as more data comes out and more solutions start to permeate the market, people will start to recognize the options that are available to them. So, right now when people think about weight loss, they think of it really in terms of, two ends of the spectrum, either a behavior program, like a Noom or a Weight Watchers or bariatric surgery. And really the middle ground is where we see a lot of the opportunity. So, a behavior program is the cornerstone of what we do. I'm a big believer in Michael Pollan's eat less, mostly leafy greens, not too much. But, the data shows that the best diet is the one that you can stick with. So, we really try to emphasize, what works for the patient and what works on a long-term basis as the best solution. But behavior lifestyle has been shown to be effectively ineffective to lose a clinically significant amount of weight and keep that weight off long term. So sure, if you want to, lose 5 or 10 pounds or drop 15 to 20 pounds by, doing a cleanse, eventually you'll regain the weight. And that again goes to the disease aspects and the metabolic hormonal pathways that your body has developed evolutionarily to avoid starvation, right? If you think about, going back to the, the histories of, the Homo sapiens sapien, the last 50 years of a high caloric diet is a high caloric environment is a blip in, our evolutionary history. So majority of the time we were actually more worried about starvation. So what happens is as I start to lose weight, if I'm overweight, or, have a high BMI and I start to actually lose weight, your body thinks that you're starving. So the data shows that if you lose 10% of your body weight, your leptin and other hormones decrease disproportionately 60%. So your body thinks that you've lost 6 times the amount of weight that you actually lost, and lowers your metabolic rate, fights to sort of hold on to all those fat cells because, it wants to survive. Even if you're still, above a quote unquote, ideal healthy weight, your body, tries to fight you to regain that weight. And so that really is where
sounds like you go back into overdrive, basically.
Exactly. And that's why, again, the research has shown that, for clinically significant weight loss, right? And again, we're not talking about 5 or 10 pounds, but, 15, 30, 50, 80 pounds, north of a healthy ideal weight, to lose that weight and to maintain that weight loss, a medical model is needed in concert with the behavior program. And that's really what differentiates us from most, companies in this weight loss sector.
It's interesting that you mentioned that. I don't have statistics in front of me, but I would imagine that maybe, does that also apply to folks that end up going through a surgical intervention, such as, gastric sleeve bypass and different types of procedures?
So it's a great question, because I think, again, going back to that care continuum with behavior, lifestyle as an first line intervention, and then there's a medical model. At some point, bariatric surgery is probably, a good option past a certain BMI. What the data shows is that the combination of a medical weight loss intervention pre-surgery, maintaining that, support system post-surgery, you get better surgical outcomes. So it's not an either or scenario. It's a stepwise approach and a foundational underpinning to a more clinically significant, sustainable weight loss. Because the problem with bariatric surgery is you can only have it once. And so the real fear is that, the patient doesn't have a good support system pre-op and doesn't maintain that support system post-op, and they regain the weight. And then they're, out even more options. And so what the new guidelines actually for bariatric surgery call for is a medical weight loss intervention, pre and post-op. And so we are working with a number of institutions to help implement this medical intervention, pre and post-op.
Yeah, it would be like putting up a 10-story house on a foundation that only maybe supports 2 stories. That's
exactly
not a good recipe for success.
Exactly. And the other area to your question earlier, that we're seeing a lot of opportunity is, if you think about the other, 200 other chronic conditions, we're working with some of these institutions around GI with fatty liver and NASH, sleep apnea, in OBGYN, preconception, prenatal, postnatal, postmenopausal, even some oncology centers with breast cancer interventions. So a lot of those breast cancer interventions in itself are weight promoting. So starting someone on a platform like ours and a medical model like ours, when they begin that intervention to help to avoid that weight gain, is clinically effective, because weight gain in itself is a risk factor for recurrence.
Part of innovating is around really understanding this problem. And it seems like you and the team really understand this problem at a very, very deep level. And that's what kind of allows you to move into this sort of solution part. Let's talk about how you guys are innovating. I mean, you mentioned this before about, look, there's 6,000 obesity medicine specialists, and there's 180 million people that are classified as obese, which means that it's a disproportionate amount of people compared to the number of specialists. How can you open up this level of access with what it is that you guys are doing? Can you talk a little bit about maybe some of the wins, some of the successes that you've had, throughout this run?
Yeah, absolutely. And that's what we did when we first initially tried to think about how do you actually solve this problem at scale? Because, the current solution right now from the medical side is more of a linear solution. So training, one clinician, training 2 clinicians, starting a fellowship program, which are all great, foundationally. The problem is that the problem in itself, and what we're trying to solve, is effectively almost an exponential problem. The rate of growth of the obesity epidemic, especially on the pediatric, children's side, is heartbreaking. And so, when we took a step back to say, all right, given the limited number of specialists, how do you actually create, a solvable, scalable solution? And that's where we leaned on technology. So we've created a digital platform that both delivers a best-in-class behavior program to the patient, but more importantly, clinical decision support and guidance to a clinician. So the idea is more of a teach a person a fish approach than try to just, put more fishermen on the pier. And so what we've done at that is also learn from the data that we have and that we continue to collect to use that to continue to refine our underlying algorithms and treatment protocols to really optimize what these interventions are doing and producing, not only from a health outcomes perspective, but correlating that to cost savings that we're analyzing, claims data, pharmacy data, to really try to create, a win-win-win across the board for the patient, for the provider, and also, the payer.
What have you found to be some of the blockers? Because maybe sometimes alignment's an issue. What a payer is looking for versus what a good outcome is from a provider might vary. How have you found it to kind of align all the different parties together? What's that been like?
So I would say, I think initially some groups are very skeptical because, again, this is a relatively new field of medicine, or they've made tremendous advancements in the last 5 or 10 years that has really helped to turn the tide on more effective treatment. I mean, about 5 years ago, there are 3 drugs, 3 medications that were approved specifically for obesity. Now there are about 6. And there are a number in clinical trials that are even reaching, bariatric surgery type of results. As the advancement comes, I think more clinicians will start to treat obesity as a disease instead of the other chronic conditions and other, related, issues, but also really try to take a step back and come up with a way that aligns interests across the board. So that's really what we try to do in terms of proving out and showing both clinicians, but also the payers, just how much of a difference we're making. So we're working with some self-insured organizations. We've been working with a few payers, both within their existing employee populations, but also on some third-party patient perspective. So really, as Dr. Roney, always says, kill them with data, right? And that really, if you think about sort of the platform that we collected, we have a whole data analytics team. And so what we're doing is not only showing that we can get, 3/4 of, upwards of 70 to 75% of the patients that currently are on our platform to achieve very clinically significant weight loss, but maintain that weight loss, and also show how that weight loss impacts care, not only in cost, not only in the near term, but medium and longer term. And so surprisingly, that information set is still somewhat, or I guess that approach is still somewhat novel or I guess new for some stakeholders, but we are starting to generate a lot of those insights and results and starting to publish that as well. So, the Brigham and Women's did an 18-month PCORI-funded randomized trial using our behavior program that JAMA published. And we're currently working with some other institutions to show the clinical efficacy of our medical model. And again, over time, we're killing them with data. We're showing them, what we're doing is effective, it's safe, and really how to actually do it at scales to actually identify and show our value proposition to a number of different stakeholders.
Yeah. Just curious, how much data is enough data? How much data do you need to produce in order for a payer or provider to actually really truly understand the value that you bring? Because, how much proof do they need? Really?
So it's a good question. I'd say it definitely varies by payer. The conversations have varied across the board. There are definitely some payers, that are a little bit more progressive. I would say the conversations that we're having with some more self-insured organizations, unions, where they really feel the need and recognize the benefit on a more immediate perspective. To your question about data, that's one of the other fascinating things about this field. um, there's a lot that they still don't know. And so what we've set up the platform to do is effectively phenotype out different obesity profiles. And so the more data that we collect, and we're starting to layer on more advanced automation tools like machine learning, to really try to optimize what our treatment protocols suggest, and incorporate a lot of data points that currently aren't incorporated in the clinical environment. So, can you start to incorporate genetics, microbiome, other types of data markers that really could help inform effective treatment protocols that, a clinician right now, doesn't have the ability, through no fault of their own, to incorporate that. And so I think that's really where the innovative advancement is going to come, both from our software platform to work with other organizations to develop more digital therapeutics or medications, to really optimize on an individual basis how to actually deploy more effective treatments. Because the fascinating thing is they think that obesity is where cancer was 20 years ago, where now they've developed very personalized prescriptive interventions. Obviously there's a lot of differences, but that's really where they feel the field is going.
It's exciting to sort of see where the trajectory is headed and how you guys are actually placed to meet that. I mean, the adage of you don't go to where the puck is, you skate to where the puck is going. It just seems like Intellihealth is doing that. So I just want to, just congratulate you on, number one, being able to kind of get it to the point where it is now, setting yourselves up for the future. I think the best is really yet to come. How can our audience follow your work? How can they get a hold of you guys? And just sort of see the good work that you guys are doing day in and day out.
Yeah, no, and I sincerely appreciate it. I would say, we've been fortunate to have great partners, and we have a lot more work ahead of us, but we definitely see, the advancements that we have made emboldens us to continue to press on, kill them with data, and just show them, how effective we can be. So, we're all, Intellihealth is on, the major digital social platforms. LinkedIn is a big one for us. Intellihealth.co is our website. Again, Sloan Saunders, CEO. Google knows how to find me and the company, but yeah, we're shouting from the rooftops, and we're trying to enlist as many people that, want to make a difference in this space, and the implications into other spaces, again, is staggering. One of the things that, is sometimes a double-edged sword, there's a lot of opportunities for us to explore. And again, there's a lot of opportunities for us to explore. So we try to, think critically about what we are focusing on. But again, if you think about it, obesity, afflicts over 200 other chronic conditions. So what we're trying to do is start at the head of the snake to really combat, one of the worst, epidemics, I would say, of our time or ever. I guess before COVID that might have been more relevant, but it's a big one. Absent climate change and COVID, I think this is towards the top.
Absolutely. So just one of the last question we like to ask is just what's one take, we've got a wide audience base here, but what's one take that you think some of these audience members can take as far as taking action? What's one thing that you want them to take away from this conversation?
I think it's going back to our North Star, democratizing and scaling access to effective obesity care. To the extent that, we can educate one more provider, one more patient, this whole misunderstanding, and there's a lot of misinformation around obesity out there. More compassion, more empathy needs to be delivered. I think, again, obesity is a massively misunderstood disease, and it needs to be treated as such. And I think the more education and the more conversations that we can start to really stop the fat shaming or the derogatory language that's used, and really, view it as a medical condition that needs to be solved. I think that's the best place, that anybody can start.
Yeah, thank you for sharing that. And it's been a really fun conversation. So for those in the audience, if look, if you found this content helpful for you, I mean, would you mind sharing it on your social media or commenting, liking it? I'm grateful when conversations like this can actually make a difference in people. And ultimately, we're here to advance healthcare forward. And I'm even more grateful when we can bring in more people into this community of innovators and doers, because at the end of the day, innovation is nothing without taking action, without having a lot of grit, without having a lot of perseverance. And Sloan, you happen to embody all those. So appreciate it. And I'm looking forward to our next conversation.
No, I appreciate you taking the time. Thanks very much.